I've got some stuff for later, Jeff, but I'm not ready yet.
Okay. Well, I can start. I'll do that. I've got a couple to show. This was for you, David. I know you'll like this case. It has a fun story. So this is a young woman. This is an old case I dug up, who actually presented with some neurologic symptoms and just limited. You guys can see my screen?
Yes.
Okay. Presented, and this is the contrast enhanced T1, and you can see this peripherally enhancing mass in the right hemisphere or the right hemicerebellum with some mass effect. Here's the coronal flare. She also has some white matter changes. She was, I believe, in her 20s. And so obviously they were worried about a brain tumor, primary. But she did have a radiograph, just a portable, but you can see there's a mass here in the posterior right chest. Wish I had a lateral. But the story is great because she was a young woman and she was a mushroom hunter up in northern Wisconsin. So once that history was put together, and I do have an abdominal CT that shows a portion of that mass, and you can see there's this heterogeneous mass in the right lower lobe with a tiny little effusion. But that was it. And I don't think there was much else in her abdomen. I think they were looking for some sort of cause. There was no chest CT, but they ended up biopsying the lung rather than the brain, and this is all blastomycosis with cerebellar involvement and a big lung mass. But so of course outdoors, northern Wisconsin are all risk factors, and I guess mushrooms grow in wet places, so a good place for blasto.
Wow.
Now here is another case that I haven't confirmed is blasto, but it's highly suspicious. I'm still waiting on some probe sent out somewhere. So this is an 8-year-old girl who presented with a pneumonia infection that was not getting better. Let's see if I can find her original Röntgengram. So nice lobar consolidation in this girl, no effusion. You wonder if there's some paratracheal lymph node enlargement. Was treated with several rounds of the usual suspect drugs, did not get better. And here she is 3 days later, and you can see she's developed pleural effusion and probably some lymphadenopathy for sure. So obviously concerned for empyema or just a pneumonic effusion. That was subsequently drained with a pleural drain, and you can see the lung does not really want to re-expand, so we have a pneumothorax, some subacute gas. She required mechanical ventilation at this point, still not responding to usual treatments. At this point, they put her on broad spectrum coverage. And then here's a CT from a day later that shows this pretty ugly empyema. And there's presumably a pleural pulmonary fistula. Any of these are potential candidates out here, but she's got this necrotizing infection communicating with the pleural space, hence the persistent pneumothorax despite tube thoracostomy. Just some atelectatic lung here. So this is probably going to turn out to be blastomycosis. They have not been able to isolate anything on bronch, and the antigen was negative, but it's not always positive. So they've sent off some DNA probe or something that's apparently more sensitive. So I'm hoping to get some confirmation soon, but it's not grown out anything else, and it's responding to antifungal therapy. So probably another case of blasto, presenting as a necrotizing pneumonia with empyema, which is what I've not seen an empyema from blasto that I can remember.
Hey, Jeff, quick question.
Yes.
With that original radiograph, you pointed out that large right paratracheal lymph node. Do you think that's a clue that it might not be bacterial? I mean, we see reactive lymph nodes, but usually I don't think of lobar pneumonia from strep giving you that large of a lymph node. I don't know.
It's funny. I always have the opposite thought because blasto.
Really?
Yeah, the fungal, other than histo, or I guess I should say, in blasto, we typically don't see lymphadenopathy, or at least that big, or pleural effusion, or if it is, it's very small. Whereas if I see an effusion and consolidation, I favor bacterial. Obviously,
I agree. Yeah, I agree with the effusion. I was just thinking about the lymph node.
Because blasto is not usually in the lymphatics. We don't see a lot of lymphadenopathy associated with it. Histo we do all the time. But for histo to present with consolidation is extremely unusual. So I don't know. That's a good thought. This is a quick one, but this is one of my colleagues had this case a while ago, but it's a fun case. So the patient had something else going on in the chest, but I just want to point out these axillary lymph nodes and how high attenuation they are, almost look faintly calcified. So the curious thing was apparently this patient had tons and tons of tattoos all over her upper extremity. So presumably this is some of the ink is high attenuation, or there's iodine in it, maybe the blues, and that it gets into the lymphatics. But I don't know, I've never noticed that before, but we don't always have the advantage of seeing the patient. I don't know if anyone else has ever seen this before, sort of dense lymph axillary nodes from tattoos.
No.
I know, 'cause they're pretty common. I mean, I guess you probably need enough of them, and maybe it's this type of ink, but I wonder if there's maybe like an iodine-based or some other high attenuation thing. She's got this left of nastiness.
Iron, I mean, you could have some iron or something ferromagnetic, because of course, some tattoos will heat up in MR magnets.
That's true, and they might use iron oxides for certain reds and oranges. Okay, and then this last case is a cute little case I was consulted on yesterday. So this patient presented with some neurologic symptoms and has an intracranial process. They were looking for a primary neoplasm, and this CT was done as a search and destroy, and you'll see there's this tubular thing in the right lower lobe that was initially misinterpreted by a resident as an AVM. But what's kind of cute when you look at it is you'll notice, first of all, if this is a draining vein, it kind of abruptly stops, and there's no feeding artery. Other thing I look for in AVMs is there's usually a hyperlucent area around it because of shunting, bypassing the capillary bed. But I like this case because you can see this little calcified nodule right here at the bronchus that leads right up to the apex of this area of increased attenuation. It's fairly low attenuation on the non-con CT. So I was fairly confident this is a broncholith with a bronchocele distal to it. I'll show you on the coronal. And then because they did an abdomen at some point, I have a contrasted study that just confirms if there was any up there. So right there you see the calcification, broncholith, and then this airway. And then there's the airway right there next to it. And then here's the CT of the abdomen that just confirms what we know. You see there's a whole bunch of these calcifications in that distribution. And then there it is right there, nice low attenuation mucus. So usually they're more central, but this was a peripheral broncholith, so kind of cute.
Very nice.
So mostly fungus stuff today. All righty, who's next? If I can find the control panel somewhere.
I'm ready now.
Go ahead.
All right, Travis, let's see. There we go.
All right, do you see a CT?
Yes, I do.
Okay. This is an acute case that came in within the last week. I'm going to show you the report first. And this CT was actually from an outside hospital, and they asked us to overread it or to reread it to look for an arteriovenous malformation. So I took out an excerpt from the echo that prompted this reevaluation. And so they did a saline bubble study, and it was positive, and they said there were a large number of bubbles, and the shunting occurred early, which is interesting. And they thought it arose from the left side of pulmonary veins and not the interatrial septum. And so they were going to do TEE and other things further to assess, but they had us take another look at this study. And I'll show you a couple of things on here. So first to show you, she has an atrial septal aneurysm, and she has 4-chamber cardiomegaly. She had a chronically occluded right coronary artery and had a prior inferior wall MI. And even without windowing, you can see there's a lot more contrast in the left atrium than there should be, which is kind of interesting. And then when we window down to more of a CT window, the first thing that caught my eye was this contrast here that's along the interatrial septum and along the roof. And sure enough, this is one of the best examples of small patent foramen ovale I've ever seen. And I'll show you here on a 3D MPR just how this, the typical location of this, the PFO, as it goes kind of from inferiorly in the right side of the heart to more superiorly in the left side. And so you can see that little atrial septal aneurysm there. So that's always look along the roof for these little patent foramen ovale, but it doesn't stop there. And I didn't actually notice this at first, but also see there's this vein. This is a collateral from the SVC or from the azygos, and I'm not even sure why this developed. But if you follow it, that it drains directly into this right superior pulmonary vein and is also contributing to the right to left flow of contrast. And so my guess is this is what was actually shunting the bubbles. It's not on the left pulmonary veins. I didn't see anything equivalent, and I think all this contrast here is from the PFO. But we have two different causes of what Leif likes to call the white smoke phenomenon here, where we have the shunting of blood, which that's high attenuation contrast in the left atrium here. So I thought this was a really cute case, and because of her heart failure, it gave us enough differentiation of contrast levels in the different chambers to be able to tease those two things out. And of course, there was no AVM in the rest of her lungs.
Travis?
Yes.
Is this streak of contrast along the left atrial border there is actually trapped in the folds of the foramen, or is it why does it have such a discrete?
This?
No, the little bit of contrast there. So what is that? That little bit of whiteness up there along the roof of the left atrium.
So that's just the PFO as it disseminates in, and I think usually it just shoots up vertically up along the anterior wall, and there's probably still a little bit of remnant of the interatrial septum there, and then it disperses up here.
So you don't think that's trapped in the leaflets of the interatrial septum, because there are a couple of layers of that foramen.
Yeah, no, I do. I think it's in between those two layers.
Got it.
Incomplete fusion, yeah, and then it just kind of disperses up here through the patent foramen. Yeah, so that's why it's directed towards the roof of the left atrium here.
Mm-hmm.
Yeah, and then it just disperses out. But yeah, you're probably right. There's probably portion of the septum here, which is why on this image it is still so discrete. All right, and then these two are mostly for Howard. And just because I know he's gained an interest in this. Now, this woman is 40 or was 42 years old at the time of this study, and you're going to see that she has a fibrosing interstitial lung disease. And it's an interesting pattern because she has these cystic spaces in the lower lobes. It's very uniform and spatially homogeneous in the lower lobe distribution, and a lot of, I think, just fine fibrosis mimicking ground glass and very sharp demarcations here. Now, I showed a case a few months ago that had a very similar interface like this, and it was a mix of, or evolving mix of organized pneumonia and NSIP. And this was 2010. I'll show you in 2017 that now she looks similar. I think she came in with an acute illness, and this was before she got transplanted. But similar distribution of findings, and they haven't progressed substantially, again, suggesting this is not an idiopathic, or this is not IPF, especially given her age and this evolution. So she went to transplant. This was confirmed to be a fibrosing non-specific interstitial pneumonia. And what's really interesting about that is the fact that, as you see, this is labeled twin. This is her identical twin sister, and this is what her CT looks like. This is not the same patient, but it is almost an identical pattern of fibrosis. And so this is another family that's undergoing genetic workup right now. We don't know the mutation. They're undergoing extensive workup. But remember, I showed the cases a couple months ago where one had more of an IPF pattern or UIP pattern, and then the sibling had a PPFE pattern. And now this is contrasting that with a family of identical twins that have identical patterns. So I thought this was pretty cool.
It's probably a TERT mutation.
Yeah, it very well may be a TERT mutation. They haven't set off all the panels yet.
Mm-hmm.
But yeah, pretty cool that it's nearly identical in both patients. So I will let you know when we get the full genetics back on both of these. But yeah, you're probably right, David. It's a TERT or another telomere or something similar. So. All right, Jeff, that's enough for me now. I can show more later. I know there's other people on here.
All right, who's up next?
I can show a couple.
All right.
right, here is a person with acute lung injury. So at close to admission, this person looks like this. You can see that the person's intubated, a gastric tube is present, diffuse lung opacities are present, patchy. At that time, right a little bit less than left. And then going forward in time, here is the next day, and you can see how this develops. So now we have bilateral diffuse lung opacities. You can also see, for those of you that haven't seen this particular device, this is called an Avalon catheter, or rather cannula, that's used for veno-venous ECMO. So there's one port in which the blood is taken out, oxygenated, and returned through the other port, as it were. So the findings are very consistent with acute lung injury edema. And the etiology relates to this person's occupation. So he works here in Utah, and it turns out that he works in a smelter, and the etiology is sulfur dioxide inhalation. It's not entirely clear what happened, that he inhaled a large amount of sulfur dioxide. Something about the respiratory equipment didn't work or something, but this is sulfur dioxide associated acute lung injury. Here's a nice article for those of you that will view this on video. This is, I'll leave this up for a second, but April 2010 from that particular journal on inhalation. And to go to the possible etiologies, you can see here sulfur dioxide, and one place you get it is in smelting and other kinds of places. So it's a matter of history, and you can see the other gases that may also produce acute lung injury that we know about. So a case of sulfur dioxide acute lung injury. This is the case of a relatively young person who has frontal and lateral projections that look like this. Obviously, the usual thing we think of every time we see something in the midline in the lower chest is an esophageal hiatus hernia. But this one is odd by virtue of the patient's age, and also somewhat odd by virtue of the discrete interfaces between it and adjacent lung. So let me bring in a CT from, say, a coronal CT to correlate that with. And you can see here the lesion, contrast medium in the esophagus. And let me bring up the axial to go along with that. So here is the lesion, and you can see where the esophageal lumen is, but it's a fairly homogeneously attenuating lesion, but it's not water, and it's obviously not an esophageal hiatus hernia. And it is on pathology a leiomyoma with focal calcifications. I didn't know what these cells, apparently, what these cells are called interstitial cells of Cajal, but they are gut pacemaker cells. So apparently those particular cells are typically seen with this kind of tumor. And you can see the other immunohistochemistry as well. So this is a distal esophageal leiomyoma, superficially looking like an esophageal hiatus hernia. And I presume he had swallowing and dysphagia. I don't know for sure. Let me show you. This one is pretty dramatic. So the background for this case is a person with the history of an esophageal stent for presumably a tumor. I didn't get that background information for sure. So here in this radiograph, you can see that she's had issues with the pleural space. There is the stent. That is from June of this year. Later on, when she became very symptomatic, her CT the next month looks like this. So she has dramatic pathology in her right lower lobe. And I'll give you a moment just to look at what that looks like. There is a lot of fluid. There are areas of apparent cavitation in the lung, certainly consistent with the necrotizing pneumonia. And that was described as such, but what was kind of overlooked is this right here. So there are some other findings, but let me show you initially what was overlooked, which is this right here. So there is the communication between the esophagus near the stent. There is some extraluminal air right there. And then if you also look at the attenuation of what's in the right lower lobe, it isn't just low attenuation of water, but you can see the similarity of the attenuation between what's here and what's in the lumen of the esophagus. So this is a fistula between the esophageal lumen through the pleura, bronchial, and into the lung. And the oral contrast medium is going down there as well. Here, subsequently performed, is the contrast exam of the esophagus. And I will show you that we confirm exactly where the leak is. So you'll see it come down, and corresponding with the CT, you'll see the contrast medium coming out of the esophageal lumen and going into not the pleural space, but rather into that lung, as you see there. So a pretty dramatic case of a fistula that initially was overlooked on the CT.
So Howard, has the stent migrated from the CT to the fluoro study? Because it looked like it was in between portions of the stent, and here on that fluoro, it looks like it's at the top margin of the stent.
So let's see. You mean migrated between there?
Yeah, because it looked like the gas was coming out, you know, out of a portion of the stent. And then on that swallow study you just showed, it looked like it was, yeah, because you see their stent.
Okay, right there, you mean.
Yeah.
So maybe the tube migrated a little bit relative to where the connection is. Perhaps, yeah. Let's have a look.
Or it's just that the air is opposed on both sides of the stent, but isn't really, like, there's not really a communication through the stent.
Yeah, I'm not pretty sure.
Yeah, because that image right there shows it's the contrast spilling over the top of the stent.
Here. So maybe this moved down a little bit to about there. Yeah, I think you're right, because the opening before was about there. Yeah, I think you're right.
Now, I guess the other question is, are these covered stents or not? And I thought they weren't, but maybe they are. I don't know. Does anybody know?
Not sure what that is exactly. No, I'm not sure what they're made of exactly. In terms of why it's coming out here, why the material in the lumen is coming out of that fistula.
Yeah, or is it, or I wonder if it's not, if it's just that it's going around the proximal margin like you show on the swallow, and it just kind of looks like it's going through when it's really not.
Something like spills over or coming through. Hard to say. I'm not sure, Travis.
I think, yeah, because I think now most of these stents are fully covered, but I don't know for sure.
Okay. Let's see this one. Okay, this one is kind of relatively straightforward, but I think this is quite a nice example of what's described as a bicuspid aortopathy. So let me show you the coronal images. Well, let me start with the CT and show you the degree of dilatation of the ascending aorta. Down here we see calcifications. The morphology is that of a bicuspid aortic valve with aortic dilatation, and you can see the pattern of it. So let me bring the coronal here, and alongside I'll bring up these images from a nice article that talks about bicuspid aortopathy. So one of the interesting things is, and there are different classification schemes for this. So for example, in terms of, and I don't typically see people actually describe it this way in radiology that I know of, but there are different ways to describe all these different patterns of aortopathy. So here in this particular patient, I think we kind of have perhaps a type 2 with the dilatation of the ascending aorta. And then in terms of the actual pattern of dilatation, which is this here, there's the so-called right-left fusion pattern, in which the dilatation involves mostly the right lateral wall of the aorta, which I think this is, versus the right non-coronary fusion pattern, in which the aortic dilatation, as you see here, involves more this portion of the aorta. So I think the case that I have is probably an example of the right-left fusion pattern of bicuspid aortopathy, at least as described in this one particular article. And I thought it's a really nice example of that. It's also a nice example of how much dilatation you can get of the aorta without being able to really appreciate it on a chest radiograph. So the correlation would be something like this, taking a slab and doing something like that. Sorry, these things shouldn't be connected in terms of that. So there's the aorta, and here is the frontal projection of the chest, and you can really underestimate how much aortic dilatation you can have without really seeing it on a radiograph, and that's a nice demonstration of that. So I don't know if we should make a big deal about this aortic bicuspid aortopathy pattern, or if it's just of mostly academic interest. Any thoughts on that? In your practice, do you ever describe it in that kind of detail? Sort of detail?
Well, I'll do an NPR and describe which leaflets look fused. I mean, we don't use any sort of the different, like type 2 or whatever. I mean, we'll just describe it as a bicuspid aortopathy with fusion of whatever leaflets. Yeah.
And then just give some measurements to the, just describe it in general terms. The root is dilated or not, and this is the dilatation of the ascending aorta, and so on and so forth. And then the surgeons will decide whether to operate on the patient. Right. All right, just a nice morphology, a nice example of so-called bicuspid aortopathy. Okay, Jeff, I can show more, but those are my cases so far.
All right, thank you. Who would like to go next?
I can try to show these cases, Jeff.
All right.
I think I've got them queued up here. So I wanted to show this röntgenogram here apropos of a case that Jeff showed last week that was lymphangiectasia. This is an ancient case of lymphangiomatosis, which has some similar radiographic findings. I'd shown a case of lymphangiomatosis before. This is the other case that I've seen. This is also a pretty old case that has been scanned here from radiographs back in the 90s. So this is what this person's chest radiograph, this woman in her 30s, looked like with this shaggy stuff in both lung bases and some pleural thickening or effusion down here. And a lateral from that era, again, shows a lot of basal predominant crud in the lungs and some pleural things. She had a lymphangiogram after this radiograph, and you can see that it's very abnormal with lots of big puddles and very extensive, you know, probably retrograde flow out into the abdomen, not stuff just going right on up, stuff in the chest as well. And there are more lymphangiogram pictures here. Just too many of these big puddles and dilated lymphatics and so forth everywhere. And I think I've shown you this picture already. Okay, so she had a CT scan around this era. So, well, that's skipping ahead. So this woman was treated with progesterone therapy for some time, and she moved out of the area. So she came back to this area only a couple of years ago, and this is what her more current chest radiograph looks like now. So you can see that her lung disease is still there, but is really diminished quite a bit. She didn't have any other therapy, but the lymphangiogram might have been therapeutic in that it might have obstructed some of the lymphatic channels, and then probably the progesterone therapy helped her out a lot here. Let's see if I have a current CT on her, a more recent CT, and you can see that indeed she still has a basal abnormality here with lots of septal thickening and sort of shagginess of vessels here, but it's nowhere near as bad as it used to be. Let me see if I can show you her earlier CT because it was a lot grosser than this, and I'm sorry it didn't come up in sequence here. So I think this may be our 12-115 CT. This is what we want here. So this is our ancient CT from the 90s, and you can see the extent of mediastinal infiltration here with these, what turn out to be dilated lymphatic channels and everything like that. So this is a tumor of lymphatics. It's really everywhere, and you can see how shaggy everything is in our lung bases, how thick the pleura is. So we've got mediastinal, pleural, and lung involvement with this stuff. And I think I'll be able to get to a lung window here. So here's her very gross looking lung parenchyma here in the bases and stuff like that. So you can see that on this exam, there's been considerable clearing here over these 20 years. And the only therapy that she got was this progesterone therapy, which was done outside, and I think ended in the 90s. So this woman got a lot better. Surprising. I didn't know that this disease could be reversible. Our other case progressed and the person died in her 30s with this lymphangiomatosis. So
does she have involvement of bone or spleen or any of those other things, or soft tissue?
Not that was noted. And when she came back to us, a CT scan had been interpreted as showing lymphangioliomyomatosis, and I think that's probably just a typographical error or a dictation error, maybe a voice recognition or a transcriptionist picked up, which is a lot more familiar diagnosis. But there were no findings on the CT scan. This modern CT scan, I think you would agree, that go along with lymphangioliomyomatosis. So I think somehow the diagnosis got perverted, maybe just semantically, but now that is in her chart. So I wrote back to the physician. I had these old exams scanned and put into the chart, and also we had pathology that documented lymphangiomatosis back in the 90s. That has now been entered into her current chart, and the physician is now aware of the diagnosis. So she never had lymphangioliomyomatosis, she had lymphangiomatosis. And there was no remark at any time in the records that I have of bone involvement. So it seems to be, mediastinal, pleural here, and abdominal involvement. Her abdominal CT scan was grossly abnormal too. I have another CT scan from the 90s that shows similar big pads of tissue in the upper abdomen as well. So this was shared between abdomen and chest.
And there were clips in the abdomen, presumably maybe they went in and resected some things in the abdomen. I think I saw here and there.
The history is very sparse, and I don't really know what goal of the surgery was. It might have been biopsy, because I think, presumption, looking at this, people would think of lymphoma as a possibility, given how extensive it is and how it involves so many different compartments.
Yeah.
Okay. So here's one of her lymphangiogram films. Okay, and that's her follow-up chest radiograph with great improvement. Okay, then I wanted to show you this. That's we're still on the same person. We're perseverating. Okay, last week there was a presentation about upside down intra-aortic balloons. And I wanted to show you our current case of this condition. This marker is part of the intra-aortic balloon, and normally the intra-aortic balloon is placed from the groin, and so this would be the top of the balloon, and the balloon is 25 centimeters long, so we might look for a marker in the upper abdomen 25 centimeters below this marker. But this one was put in from the top. It was put in from the subclavian, I think, or the axillary vessel, or maybe the jugular. Maybe the carotid. I'll have to go back and look. I don't think they would use a carotid for this, so it was probably subclavian. So this is actually the bottom of the balloon, and the tip of the balloon we've seen in the upper abdomen. So this one is upside down, and it's still not a very good position. So you don't want the balloon blowing up in a small vessel such as a subclavian artery. You want it in the big vessel, which is the aorta. So this needs to be at the bottom of the aortic arch to give you maybe 2 or 3 centimeters cushion against its going out into a branch vessel. So this thing is too high, and we've been talking to them a lot. If this had been placed from the groin and you had the tip in this location, you'd say pull it back, and they would do that because they can safely pull a catheter back. But when the thing is put in from the top, they would have to push it in, and that runs the risk of taking contaminated catheter outside the patient and pushing that into the vessel, and then resulting in infection and sepsis. So they're really sort of powerless to push these things in farther and get them to a better position. So I think there's a risk here of this thing with the balloon blowing up here in a small vessel, such as a subclavian, of damaging that vessel. And this has been there for several weeks. They're really powerless to advance it because they can't do that with safety.
Now,
So,
David, presumably there's a little gap between the tip, the metallic tip that we see there, and the actual balloon. Is that usually a gap of a centimeter or two to the start of the balloon?
I don't know for sure. You know, there have been a few cases I've seen of radiographs where the balloon is inflated, and it seems to taper pretty close to the marker, but I'm not absolutely sure about the measurement. Does anybody know? Okay.
I thought a gap of a little bit, maybe a centimeter or two, but I can't remember either for sure.
But even if it's a centimeter or two, it's still,
Close.
too high, right? So this is makes me a little uncomfy. And the final case I wanted to show you is a case sent to me by first of all a colleague who's now in private practice and then chucked radiology altogether and is now retraining himself as a software engineer. So this is Thurman Gillespie, who used to be one of our trauma radiologists. He sent this case of this woman who has these indolent lung nodules that have been there for several years. So let's look at this exam. These exams are 2 years apart. And I think this is the earlier exam here on your right. This is 2013, and the exam on your left is 2015. So there are some small nodules out here against the periphery. There's a nodule here along the spine. This is not just that fibrosis that goes with an osteophyte. There's actually another nodule there. It's not very apparent on this exam. A few little other things on the other side. And then 2 years later, we have this exam. There was an intervening exam too. And you can see that there's been some evolution. These nodules here were already cavitary, but they're a little bit bigger at this time. The nodule that's out near the axilla there is a little bit larger. And the nodule here in the right base near the spine has now cavitated. So we went through the chart. They went through the chart very carefully at the time that this case was presented, and there wasn't any evidence of tumor in these things. The progression is slow of these nodules, and the woman does have rheumatoid arthritis. She's 75 years old, and these are probably rheumatoid lung nodules with slow evolution and maybe a little bit more cavitation with time. So rheumatoid nodules. Okay, those are the cases.
All right, and your nodules, many of them are subpleural, which seems to be the location of many rheumatoid nodules for whatever reason.
And it's interesting that in the cases I've seen of Kaplan syndrome, they also like this subpleural location too in upper lung. So you see these deposits out near the edges of the lung.
Yeah, it almost makes you wonder if maybe it's an intrapulmonary lymph node that develops necrosis or something, because they're often very well circumscribed. And I know that we've shown several examples throughout this conference over the years, and they seem to have this certain look you just kind of know.
Yeah.
Great.
Awesome. All right. Who else? Anyone else? Brent, I see you're on.
I have some cases, a few
That
cases.
would be great.
Okay. This first case is a case of a 77-year-old woman who came in actually for a screening for metastatic disease in the setting of colon cancer. And this was an incidental finding, actually traveling originally from Jamaica, moved here, and lungs looked like this. We didn't see any suspicious nodules. They were suspicious for nuts, but you can see that there's a lot of architectural distortion, reticulation, sort of a lobular distortion with some areas of air trapping. Bronchial walls are thick, and a little bit of reticulation suggesting some fibrosis. And her history is that her family and she have her entire life cooked with wood-burning stoves, and her chart history says, her medical history says that, you know, these were outside settings. She cooks outside, like to cook outside, but you know, actually we believe that her family was cooking in tents outside using wood-burning stoves, and presumably this is a nice case of hot lung, where you have a blend of you know, a bronchiolitis obliterans and what looks like a mosaic attenuation from air trapping, some, you know, elements here of a chronic HP and bronchiolitis obliterans from this wood-burning stove that her family has used her entire life. So,
Did you call it a hot lung?
HUT, H-U-T.
Hot lung, okay.
So sort of I know I showed another case not too long ago of a looked like a bronchiolitis obliterans, and that patient also had a history of wood burning, stove exposure, and more in kind of a casual you know, setting here. So this is a much more dramatic case of presumably what is you know, wood burning material exposure here causing this pattern. So.
Yeah, presumptively, that's a good thought.
Okay, and here's another case that just saw this week. This is a patient with a recent perioperative myocardial infarct, and you can see here that there was gallbladder surgery, and now there's an abscess there. This is several weeks after surgery, and so that's being treated. But in looking at the heart, you know, we can see signs of the infarct. Now, there was at cath, this is an ST elevation MI, and at cath there was 100% occlusion of first diagonal branch, and you can see that there is this subendocardial perfusion abnormality here that you can see, and this is in the anterolateral aspect of the wall here. And what wasn't originally appreciated, I think, overnight is that scrolling through, you see some irregularity here. The wall looks abnormal up here in the distribution of the MI, and let's take a look at the sagittal images here. And on the sagittal, you can more readily see that there is a what looks like a small defect in the wall with extension of contrast outside that. So presumably this is a small pseudoaneurysm due to wall compromise in the setting of this MI. And this MI was about 3 weeks prior to this, 2 to 3 weeks prior. So that's a good time period. And here's the coronal, again showing that little divot there that looks like contrast is extending outside the cavity. So we're going to get hopefully an MR on this and just take a look at that. But presumably this is a post-MI little pseudoaneurysm wall rupture, you know, due to that MI. So I just thought that was an interesting case. There's no hemopericardium at this point, which is great. But yeah, it certainly looks like a small little pseudoaneurysm. Do you all agree with that?
Sure looks like one.
Yes.
Yep.
So we'll, you know, bring in the MR once we, you know, I don't know if they're anxious to go in there immediately right now since there's some other problems going on. Here's another case, just quick case here. This is a patient in the 50s who has this CT appearance, and this was on a CT that was done about you know, a year prior to the next CT I'll show you, and has ground glass opacity here in the lower lobes. The right middle lobe has some septal thickening here. You could even start to, if you want to, you could call this some crazy paving in these locations. So on the soft tissue windows, not much going on at this point. Let's go on to the CT that I saw more recently. And here we go with the lung windows again, and you can see that this has become more confluent. Now there's consolidation, more ground glass here, more septal thickening. And of course, if you look at the soft tissue windows, you can see that there's some macroscopic fat there. And this patient's history, now tell me how this works, because this patient's history was history of mineral oil enema use. So I'm not sure how that works, but presumably this is lipoid pneumonia, and I'm not sure if additional, the enemas were being,
Siphoned.
Brad, it's the worst case of reflux you'll ever see.
Yes. So there's some mechanism here, but presumably lipoid pneumonia caused by something related to the mineral oil enema. All right, and then just another case here. So this was, let me see if this is the first or the second CT. So this was kind of the first CT here. We have this patient is a patient in the 40s, patient in his 40s who has CT coming in about a week prior to the second CT I'll show you. And notice how, the lungs have multiple areas of ground glass opacity, and you start to look, and many of these are very nodular. And looking at this, I probably would just say there's some sort of bronchiolitis going on and so forth. Look at the heart, not too bad. Let's take a look at the follow-up a week later. And in between, I'll give you the further history that this is a prior EMT who was an EMT many years ago, who had a history also of opioid abuse more recently. And you can see that within a week, the heart is dramatically different. The right ventricle and right atrium are enlarged. The septum is straightened here. And here's what his lungs look like now. And even more nodular, multiple, ground glass and relatively solid looking central lobular nodules. The team called me up after the CT was done and said, well, he's acting funny. We're concerned that he's illicitly using drugs. And so presumably this could be, a good case of excipient lung disease. So, it has access, has, knowledge of how to administer drugs. And you can see down here that even, the lung base has developed some peripheral larger nodules that could represent little embolic events from, crushed tablets of some variety. So not sure if we've confirmed this yet. I'm going to check again, but there's a high suspicion that this is a case of excipient lung disease, and certainly the right heart, relatively acute development of right heart enlargement suggests that is a possibility along with the background of lung findings. So,
Ray, can you make a MUPS for us and maybe focus on an area anteriorly where we can see the nodules?
Yep.
Can you connect them up to intralobular pulmonary artery segments? Or is it hard?
Yeah.
Certainly there's a branching pattern here. Very, for bronchiolitis, it's very well defined. So, I agree that in this misled me at first, and I thought that, it looked more to me like a bronchiolitis from airway, sort of based disease here. But it's very, very nice tree inside whenever, of all the cases that we've seen on this conference and also here, when we see such a well-defined pattern, we start thinking about excipient lung. And certainly with this acute right heart strain, I have a high index of suspicion that this could be excipient lung.
For that too.
Yeah, so you can sometimes mag up and see if those are pulmonary arteries, lobular arteries in between the veins, which look normal, so that the tree in bud is the pulmonary arterial bud rather than the airway, right?
Right.
And David's trying to say something.
Brent,
Yep.
was that case report of this condition that was in the New England Journal about 2 weeks ago? It was called angiogranulomatosis or something like that. There's images in clinical medicine. Did that come from Emory?
I don't know. I'm not aware.
Yeah.
Did it?
Yeah, I did. One of my residents here sent it to me.
Oh, it did. Okay. I did not know that.
Yeah.
Unfortunately, that's probably one of the cases that we read and didn't get credit for it. So
That's the same comment I made last week, but
I'm not
not
bitter.
that anybody's bitter.
Not that anyone.
I think the only thing that doesn't seal it in this case is that he doesn't have an indwelling catheter, but if he can access his own veins, then
Yeah.
There's enough clinical suspicion, but yeah, we'll follow this up. But anyway, those are my cases.
The other thing that's missing here that would be helpful is to see the acute pulmonary artery dilation. His pulmonary artery looked okay, his main PA, but that could dilate right up along with the right heart.
Yeah, I mean, it's certainly, if we measure this and it looks a touch larger than the aorta. I don't know. For me, that right heart is so condensed, that it kind of overrides.
Right.
The
We're all
PA.
with you on this.
Yep.
Yeah. But anyway.
Jeff, I have one more case I can show that I just dug out of the UCSF teaching file to go along with David's.
That would be great. We got a few minutes left.
So here we go. This is the only case I can find from the UCSF teaching file. Guy came in 2001. This is 2004. He's 17 years old at the time. And you can see on lung windows just the pronounced peribronchial wall thickening or cuffing or infiltration. And you can just see how it extends out from the hyla. And when I show you on soft tissue windows, you'll see there's just diffuse infiltration encasing all of the vessels or surrounding all the vessels. Really marked thickening of the pleural, and even, I don't know, this proliferation of the extrapleural fat here. So this was the one case that I could find here of lymphangiomatosis. Now this patient had extending all the way into the abdomen. He was younger. He was diagnosed a few years before that, back in 2001, or I was trying to dig up any of notes. This was pre, a robust electronic medical record, so there's not much left. But he did have a pleural and lung biopsy that confirmed the diagnosis. And David, in contrast to your patient, this patient was treated with an alpha, I think an interferon alpha that they use. And I pulled up one article where it talks about progesterone receptor being positive in a few cases. In some patients, like this one, the interferon alpha 2B therapy, inhibits tumor cell division and then has some VEGF effects as well. It sounds like he was treated, his symptoms got a little bit better, his PFTs declined, and then he was never seen here again after 2004. So I don't really know what happened to him beyond then. The bones,
I was going to ask you about the bone involvement.
I mean, his ribs look abnormal. I think they look abnormally expanded, but they're not that typical, lytic destruction you see with the Gorham-Stout disease. But I don't know.
You kind of wonder if there's at least maybe some.
Yeah. The vertebral bodies here.
Yeah, just for a young guy to have bones that look like.
Sure. And you wonder how large he actually is. I mean, he should be a nearly fully grown.
Yeah, the radiograph looks
17. Like. Yeah.
I just wonder,
the radiograph actually. I just want to see what his skeleton looks like.
He looks kind of small.
his ribs are big. I wonder if the same lymphatic channels are dilated in his bone marrow too, and the ribs are all just diffusely expanded because of that.
And his vertebral bodies look abnormal too.
Right.
So
it looks porous.
Yeah. So it sounds like there's still no good treatment for these. Now, obviously, if one thing worked, they would use it, but it sounds like a lot of different things they found.
Targeted antibody. Say
that again, Jeff?
I thought there's some new drug, like an AB or something, a monoclonal antibody.
Yeah, maybe for an orphan indication. I mean, it's such an uncommon disease.
Yeah. Well, our patient's getting a lymphangiogram, I think, next week. But ours is probably a lymphangiectasia, not a lymphangiomatosis, because we didn't have as much soft tissue thickening.
Yeah.
But it's fascinating.
And so the distinguishing characteristics, so this is more like David mentioned, this is like lymphatic proliferation and infiltration, like almost like a neoplastic
Yes.
or tumoral
Right.
process, right?
And where versus lymphangiectasia is just dilation of the pre-existing lymphatics. So when I get our lymphangiogram, I'll show it. I suspect it's going to look different than David's. It's not going to have that diffuse sort of pooling everywhere, but rather just show dilation of the channels in the lungs. You
wonder about if they've tried other things like Avastin and all these other VEGF inhibitors, because they're saying here that even propranolol may reduce VEGF. I don't know.
Maybe even sirolimus, like they use for LAM.
Yeah.
For the mTOR pathway.
Yeah.
Travis, could you scroll back to the top of this article?
Oh, sure. Yeah, this is just, I don't know, lymphatic research in biology. Not sure if you have a subscription to that one or not, but we will, yeah, it sounds like it looks like there are a few other articles as well. But one of the things that prompted me to look this up too is when you were mentioning progesterone, I was wondering if it was a female predilection, but of course this patient was male.
Right.
And it says here there is none, which, I don't know, further confuses things.
Okay, well, thanks everyone.
Thanks,
guys.
All right, we'll skip next week because it's Thanksgiving, and we'll touch base regarding RSNA week, but I think we'll hold the conference.
Yeah, I'll be back.
I'm around, I think. I mean, I'm here.
Okay, thank you.
All right, guys. Bye.